Hi, my name is Qiang Cai. I'm a professor of medicine and a gastroenterologist at Emory University in Atlanta, Georgia. I also direct the Advanced Endoscopy Fellowship Program in our center. I appreciate GIE give us an interview regarding our paper, Outcomes and Quality of Life Assessment after Gastric Peroral Endoscopic Pyloromyotomy, which published recently at in GIE. Gastroparesis is a disorder with delayed gastric empty in the absence of mechanic obstruction. It is a chronic disorder with symptoms of nausea, vomiting, bloating, and abdominal pain. Common causes for gastroparesis are diabetes, post-gastrointestinal surgery, and infection. Some patients do not have identified cause. We call these cases idiopathic gastroparesis. Therapeutic options for gastroparesis include medications, endoscopy therapies, and surgery. There are only a few different medications for gastroparesis, such as Reglan and erythromycin. These medications have a limited therapeutic effect on gastroparesis and come with some undesirable side effects. Endoscopy therapy, such as Botox injection and gastric electric stimulation, can be helpful, but only in a few selected group of patients. Surgery for gastroparesis is too invasive. Gastric peroral endoscopic pyloromyotomy, we call the GPOM, is an immersive, minimally invasive therapeutic endoscopy modality for gastroparesis. Since the first GPOM case reported in 2013, a few studies with less than 100 patients have been published worldwide. These studies provide some data on outcomes in patients. However, the quality of life after GPOM procedure had not been studied. The paper we just published is the first study to examine quality of life after GPOM procedure. We followed 16 patients at 1, 6, and 12 months post the GPOM procedure and found that 80% of patients reported improvement of symptoms of nausea, vomiting, and increased peroral tolerance. Since GPOM is a new endoscopy procedure, now there are many unknowns. There are no studies so far to compare the outcomes of GPOM with other procedures, such as Botox injection and gastric electric stimulation, etc. We need randomized clinical trials to compare them. How to select a patient for GPOM procedure is another unknown. Now we cannot predict which patient will respond to GPOM therapy. We believe that patients with motility disorder mainly located at the pylorus are likely to be more responsive than those with motility disorder located in other anatomic areas in the stomach, such as in the gastric body or the fundus. Therefore, we need more detailed gastric motility information before we select therapeutic methods in the future. Adequate pyloromyotomy is another important factor that can affect the outcome of GPOM. The essential requirement for adequate pyloromyotomy is to successfully identify, expose the pyloric muscular ring. Therefore, how to identify the pyloric muscular ring and how to assess the adequate myotomy are important topics in the future. In the study we just published, we performed gastric empty study before and after GPOM to assess the gastric empty status as a surrogate for adequate myotomy. Ideally, we should perform direct measurement of the pressure at the pylorus. Additionally, the long-term outcome of GPOM is unknown, given that this is still a relatively new procedure. Our study only demonstrated improved symptoms and improvements in quality of life at short term. Currently, GPOM procedure is performed only at a few academic centers in the United States. Another question for future study is how to train more GI doctors to perform GPOM procedure. In conclusion, GPOM is a new and promising endoscopic treatment for gastroparesis. There are many unknowns, and we have many to do in the future. Thank you.